everyone. On behalf of Jewish Child and Family Service, I'd like to welcome you to the first of a series of 2 webinars acknowledging Substance Use Awareness Week 2020. I'm Ivy Kopstein, the coordinator of the Substance Use and Addiction Support Service at Jewish Child and Family Service. And this being our first webinar, I'm nervous. So forgive me if I'm going to read a lot of what I have to say. There's something nice about being able to attend from the comfort of our homes, especially as the evenings get shorter and colder. But wherever we are in Manitoba, we are on Treaty 1 territory, the traditional territory of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. I'd like to introduce my co-worker, who's there somewhere, Dorit. I'm not sure where she is, but anyway, she's here, as well as Al Benarosh, the Executive Director of Jewish Child and Family Service, and Shanna Menkes, who's our Director of Operations, who will be the tech support. The speakers I will introduce a bit later. Dorit will be the lead in this coming Monday, November 30th, when we talk about gambling, a Jewish perspective. You will enjoy hearing from our speakers Yael Landa from Beit Shuva in LA, a guest from there who will share his personal story, as well as our local Bill Smithingale from the Addictions Foundation of Manitoba. Just a couple of housekeeping details. No, it's not where the exit signs or the bathrooms are. It's that your mics will be muted and your cameras will be off. But please use the chat for questions that can be asked following the discussion. The session will be recorded to be available for a later date. The opioid crisis, which seems to be the driving force in the increase in overdoses, continues to devastate communities and families across the country. In 2020, between January and March, 1,018 deaths occurred, of which 96% were accidental or unintentional, and they are sharply on the rise. The COVID-19 pandemic is adding to the ongoing public health crisis related to high rates of overdose and deaths, as well as acute substance use harms. The Canadian Centre on Substance Abuse and Addiction reported in April that Canadians under 54 were drinking more due to COVID-19, stress and boredom being cited as a major cause. We're all having to adjust to this new normal, and it's even more difficult for those who are marginalized, have fewer supports, or are afraid to seek help. The Jewish community has not been immune to mental health, substance use, and addiction issues. We work with people who suffer from trauma and a complex set of issues. We work with families who've had to grapple with how to support their loved one and take care of themselves during a very difficult time. We've seen families face an overdose scare or unfortunately losing a loved one. We have also seen the impacts of COVID-19, including those relating to overdose. But we've also seen resilience, creativity, and strength as people navigate through their lives and our new reality. The theme for this year's Manitoba Substance Use and Addictions Awareness Week campaign is Change Begins With Me. It acknowledges that we can all play a role in bringing about positive change. Our wish today is to reduce or eliminate stigma and judgment, which are significant barriers to seeking help. We want to encourage dialogue towards understanding and offer a safe, non-judgmental space so individuals and families can heal physically, emotionally, and spiritually. If you are concerned about yours or anyone else's substance use or addictive behavior, JCFS can provide a safe space to access and connect with resources. To begin our conversation tonight, we will present some important and basic facts about overdose. Then we will look at substance use, addiction, and overdose through a Jewish lens, and how we as a community can help reduce the harms. We're thrilled to have our guests today to shed light on this dark subject. I'll introduce them as they appear, and that'll be followed by a discussion led with questions. So let us begin. We are fortunate to have Megan McWilliam, who will share her own story and insights with us. So welcome, Megan.
Thanks, Ivy. Like Ivy said, I'm also working off of notes, so excuse me if I'm glancing down. It's hard to keep half my life sort of contained without having something to go off of. As Ivy said, my name is Megan. I grew up upper middle class in Tuxedo in Winnipeg, and I went to a Jewish private school until grade 8. I've always felt more culturally than religiously Jewish. I'm the youngest of 3 daughters with a large age gap between me and my 2 older siblings. My parents have been together since they were teenagers. My dad is an addict alcoholic in recovery, and there is addiction on both sides of my family tree, both to substances, alcohol, and gambling. I probably had feelings of isolation or difference as far back as I can remember. It's an ever common feeling with addicts of always feeling alone, even in a room full of people. In hindsight, I'm not sure if that was my real reality or just my own reality. Now looking back, I kind of look at it as a really early manifestation of like the self-centeredness that my addiction brings about. I always had lots of friends and people around, but I never really felt a part of, never really felt included. I became rebellious and problematic with my peers and in school from a pretty young age. I still excelled academically until I hit junior high. I was involved with extracurricular activities, classes, team sports, lessons, all of that. But I became more consumed with what I wanted to do and with myself and my own self-centeredness by about grade 9, so about 14, 15 years old. By grade 9, there was already some sufficient and longstanding turmoil in my household between my parents surrounding particularly money. My upbringing was already quite different in terms of the opportunities I was afforded compared to that of my sisters. Almost immediately, I sort of took it upon myself to start doing what I wanted, when I wanted to, and trying to stifle with that my constant loneliness and that feeling of difference that I mentioned. Using gave me a built-in social circle and an ease of spending time with these people who had similar interests. I escalated pretty rapidly in my using, from pot to mushrooms to chemicals and eventually everything else. I sampled anything that came my way, and I had very little fear of trying drugs. I made rules for myself in my using, such as I won't use anything that doesn't come from the ground. I won't snort anything. I won't smoke anything I can snort. I won't inject anything. And one by one, I broke all these rules. And again, looking back, I can see very early on how that was my addiction showing its face. By 17, I had tried opiates a few times. And by 18 or 19, I was solidly addicted. I had moved away to the other side of the country, and I came home very committed to using heroin. I got into every kind of trouble that you can imagine that comes along with addiction: violence, crime, petty theft. I dealt with police brutality. Opioids were the first thing that I had ever used that upon using them, there was like a major shift in my entire world, like a paradigm shift of my mind. It was completely mind-blowing to me to know that I could quiet the world and be as numb as they made me. And at the time, I felt very carefree. This is in the very, very beginning. Opioids are all consuming in a way that I can't even properly describe. They manage to erase everything else except for themselves in your life, and they do so very insidiously. Everything kind of drops away until it is just you and the drug and you, and suddenly you don't have anything else to lean on, fall back on, or reach out to. My family, who despite the tension that I mentioned in my household had always been tight, disappeared from my life because of my own actions and as well as their own. They started putting healthy boundaries in place, excluding me from the household and not wanting to support my life if I wasn't going to make the right decisions. At 20 years old, my boyfriend passed away of an overdose on fentanyl. And this is at a time, this is 2009, it's before fentanyl was the fentanyl that we know today. I'm talking about a time where when I called the paramedics following his overdose, I had to explain to them how he could have possibly overdosed on fentanyl. They had no point of reference for how that could have even happened. This was also at a time where there was very little availability for Narcan, naloxone, and only really fledgling methadone and harm reduction programs in the province. I had already seen many overdoses. I had called more ambulances, and I had administered more naloxone to friends than I can really care to remember. And this is, as I said, 2009 already. But his overdose was very different. It was very personal, in my face. And it's a trauma that I carry every single day in my mind and my heart, still today. I was left very lost after his death. Our codependency and losing myself in the drug had left me really a shell of myself. As I mentioned, I had been removed from my family home sometime earlier, and I had sort of been floating from place to place for a while. I made my first attempt at recovery following his death. I had put myself on at that time, there was a long wait list to get into a methadone program. So about 8 months prior, I had put myself on that wait list in a period of withdrawal where I was just reaching out for something to feel better. I was unfamiliar with the time about the process and how long it was going to take. And I don't know if it was karma, fate, luck, chance, but in the days leading up to his death, I had received a call at my parents' home that informed me that my place on the wait list had come up and that I was going to be eligible to enter methadone treatment. The doctor that welcomed me in to methadone treatment likely saved my life. I have no qualm saying that if I hadn't begun drug replacement treatment at that time, I probably would have been dead in days, weeks, or months. I didn't stay clean then, but it was my first attempt. And this sort of began my 20s, which were spent largely in and out of treatment, detox, with periods of sobriety and periods of relapse, both long and short. I went to treatment the first time for the summer following his death. And from that treatment center, I took away a better appreciation of how much work was going to be required of me to get well. Someone put it to me, and it still sticks with me now, that all of that effort and time that I was putting into using and getting and finding ways and means to get and use more, I had to be willing to put that kind of effort and attention into getting well. And it's something that has stuck with me all these years. I really wasn't ready at that time, but I had heard and begun to appreciate what was going to be required of me. I refused to give up my old friends, and I couldn't wrap my head around the fact that other people were able to use safely and non-addictively, and I just couldn't. Again, I tried every way to manage and control my disease, making rules for myself, and of course I could not. Eventually, I got off of methadone in my mid-20s, monitored by doctors, and I did relapse about 6 months later. I likely really didn't have any of the skills that I thought I did in place. I returned to treatment a second time, and I had an excellent experience there. I did go back to using, once again, other substances, feeling then that I could control this by simply not using opioids. I got back on methadone and eventually switched to Suboxone at the very beginning of its availability in Manitoba. I held down some reasonable clean time following my second rehab, about a year and a half. I went to 12-step meetings with regularity at this time, and I feel that 12-step philosophy is extremely valuable and has played a huge part in my awareness and understanding of my disease today. I learned at that time about myself and my terminal uniqueness. And terminal uniqueness is a term that we sort of use to describe that feeling common in addicts that my struggles, my worries, my woes, my journey is so different and so hard and so extreme that no one could possibly ever relate to it and nobody could possibly ever have these same struggles. Eventually, I did go my own way again, which of course was back to using. And by my mid-20s, I saw really more of my friends die than I can count. At 31, I truly have more friends underground than above today. I began relapsing heavily with opioids in my late 20s once again. I had moved away from Winnipeg again for the second time. I was trying to work in a career and put together a relationship that I thought was functional, but in hindsight was still highly codependent. And eventually that dissolved as well. And it left me feeling somewhat desperate and beyond help. At that time, I had started skipping my medication for days and weeks at a time in order to use successfully and sort of planned binge using around this. In my late 20s, I overdosed in my parents' home, and that trauma is really more my family's and my father's than it is my own. He is the one who found me, had to call paramedics, etc. And it was a wake-up call to me, but not enough to completely deter me. I still consciously plan these relapses and binge using, and I began using meth at this time, which largely just kept me going and gave me more hours in the day with which to use what I really wanted to, which was opioids. I was left in a very desperate and helpless state after my last relapse, and I feel that I really only made it out by the skin of my teeth. At 19 years old, I hadn't looked like I was going to make it to 20, and at 29, I really didn't look like I was going to make it to 30. I eventually admitted and came clean to the doctors and nurses who supervised my medication, my Suboxone, what I had been doing, and got back onto a well-supervised Suboxone regimen. I attended treatment a third time with my parents' support. And this time when I attended, I found that the things that they tried to teach and preach to me, I already knew. I just wasn't doing them. I wasn't putting them into action. I was familiar enough to try to start putting them to work. And for whatever reason, this time it stuck. I don't know, honestly, if it's because I was older, because I was more ready, if because I really knew that my body and my mind did not have much more that it could give to this disease before it finished me. If I didn't want to put my family through it, I had so few friends left alive, and I had watched the destruction in the wake of all of their deaths to their families, or it's a combination of all of the above. My family, as I mentioned, were always ready to rally around me if I were to make the right choices. And I was extremely lucky to have them right there this last time. And I made a concerted effort to make up for the time that we've lost every single day. I maintain my recovery today with honesty. I have the most honest life and relationships that I have ever had. Lying is inherent in the disease, and I believe that honesty is inherent in real recovery and wellness. I try to take care of myself and those around me. I stay busy, I eat and sleep regularly, and I keep my commitments, however small. I cherish and nurture a loving and incredible relationship with my family. It will take years, maybe forever, to build back all that I broke and all the trust that I destroyed. But having their support unwaveringly has been the strongest leg I've ever had to stand on. We still have challenges within our family and disagreements, but our relationship today is tied, as I said, inextricably to honesty. I find that I have been okay through this crazy period of COVID-19. I made a more concerted effort than ever before to stay busy and to stay occupied. I started a small online business. I started picking up skills that I could learn online, little things like handwriting, how to draw certain things, calligraphy, and braiding my hair. Though I have to say that largely one of the greatest reliefs of my being sober is that I feel okay today alone with myself and with my thoughts. For years, as I said, I needed to be surrounded by people, busy and pretending to be social, when really I felt so isolated and alone the whole time. Today, being alone is a gift. The fact that I like to be and am happy to be alone. It's one of the many ways I'm able to observe in myself just how far I've come. The fear of being alone, though always feeling it, was a constant through nearly my entire life, and that's since long before I ever picked up. I have strong feelings towards harm reduction. I believe it is the only way. I believe that being on replacement drugs is the singular reason that I am alive today. I have dealt with a certain amount of stigma surrounding my own use of Suboxone, and it usually comes within the medical profession. Right now, I'm planning for a major dental surgery, and just figuring out the red tape of how to sedate me, how to deal with my aftercare has been a huge strain. But aside from that, I don't know that I have ever personally myself felt super stigmatized. And part of that is that my addiction is not a secret or a shame or a point of guilt to myself or to my family. Big picture, however, I see the detriment and despair caused by the systematic stigma towards addicts. Lack of resources, lack of interest, and lack of caring has made for, as I said, a very desperate situation. I know that my access to needle exchange programs all over this country is the single reason that I have no permanent disease or illness or long-term physical effects from my using, aside from having terrible dental issues, which in the scheme of things is a very small issue. I believe that taking care of those who are the most in need and often the most neglected and marginalized is not only vital, it's the only responsible thing to do. Especially right now with COVID making access to treatment and meetings and care a challenge, there's more idle time to be alone with one's thoughts and mind and self than ever before. And your own mind is not a safe place in active addiction. Addiction is an equal opportunity abuser. It doesn't see race, sex, sexual orientation, socioeconomic status. It affects and reaches all equally. My story is not unique, but the ending is. I am one of the few, and I mean very few, who will ever get a chance to see the other side and all its possibilities and be granted a chance to live again, or maybe in the first place. In addiction, I never specifically wanted to die, but I felt at times as though there was no way out, that my situation was so desperate and so very hopeless and miserable that I couldn't see how it was logically possible to go on living. I'm truly blessed today to have been able to leave that hell of my own creation, and I'm hoping that I've really only just begun that journey. I want to stress, my story is the story of millions of other addicts. There is nothing particularly special or unique about it, aside from the fact that I am alive and here to tell it. And that's it.
Thank you so much, Megan. That was so articulate and moving and inspiring. Thank you so much for sharing that with us. So now I'm going to introduce each speaker. I'm going to start with Jay, then Kim Bailey, and then Michelle. I'm going to introduce each one of them just before they speak and just share briefly about what their role is. So Jay is the clinical director of JACS Toronto, that's Jewish Addiction Community Services. Graduated McMaster University with an addiction study diploma in 1992, and he continued his studies at George Brown College and graduated from the Human Service Worker program with a major in mental health and minor in corrections. Jay started with JACS Toronto, consulting, facilitating, and training in 2004. He has been the program and outreach manager. He became the program and outreach manager in 2009 and has been the clinical director since 2014. Jay brings 25 years of experience as a counselor, program developer, and facilitator to JACS. His unique blend of counseling skills, humor, and energy has helped JACS become the leading Jewish addiction and mental health agency in the general Toronto area. So, Jay, what do you do at JACS?
Well, first, let me say thank you very much for inviting me out. It was a long walk from Toronto to Winnipeg this evening, but I seemed to make it from the living room to my office bedroom. I have to say I feel very old next to Megan. And Megan, congratulations on all your success. I wish you many more happy 24 hours.
Thank you.
Okay, a great story. I should bring you over to one of the recovery homes that I work with. So what do I do at JACS? I'm the clinical director. So really my job there is to handle the more complex cases that come through our doors. Well, come through our phone lines and our Zoom codes these days. Ensure that the quality of care is the best that we can provide. We look at our programming and do needs assessments on with the community that we serve and the general community at large. And we try and tailor our programming to fit community needs. There's always been a debate in charities that do we fit our programming to fit our funders' wants, or do we fit our programming to fit our community needs? And oftentimes our funders will say, well, I want money to go to a certain area, Holocaust survivors of, things like that. And we've always maintained that the integrity of the community is based on the clients that walk through our doors. And sometimes that's been a hard road to sow for some of the donors, but we, at the end of the day, we know that we're doing the best we can to serve our community and the greater addiction community of really Canada these days, as we go across Canada out to Vancouver, up to Winnipeg, and starting probably, well, it was supposed to start in the fall, but probably next year start doing some more work out in the Maritimes. I think that's pretty much
the population you serve, the demographic, just quickly, basically.
Yeah, so maybe I can talk about that. So we see a variety of people, probably about 60% are Jewish. We're open to all denominations. We see a majority of male clients, probably, I would say probably 3 to 1 on male clients versus female clients coming through. And that still has a lot to do with stigma. In my feeling, it has a lot to do with stigma. If a single woman with a child comes through the doors, just getting that person to the doors is a big deal, because there's a lot of fear that they're going to lose their child, that people are going to, stigmatize them. There's still an old boys club mentality, an old, I don't want to say it's an AA. AA doesn't have the ownership of it, but there's kind of an old kind of, if there's a guy that's a hard drinker, oh, look at the good old boy, putting back a few pints after work. And if you see a woman in there after work putting away a few pints, there's a very different thought. So I think because, we're breaking that stigma, I'd like to say. We do have a few women's groups. We have an Orthodox women's group. We have another women's group that runs, non-denominational women's group. But still, I think 3 to 1 or 4 to 1 is probably the numbers that we see. We're not seeing, the numbers that have decreased are on youth. And I think that's partly to do, and this is just anecdotal, we haven't done any studies, but I think part of it is due to legalization of pot, that once pot became legal, a lot of parents looked at it and said, well, it's not a problem. And I think also a lot of youth, that once it was more legal, it wasn't as taboo. They could use or not use. So it's kind of like Holland in that way, that once you had free reign of it, it's like, okay, I can smoke whenever I want. So why don't I do my work first and I'll smoke later, rather than smoking any chance you can get. So I think it's been a good, in my mind, I think it's been a positive, that there aren't as many kids coming through, or youth coming through the door. And I think it's because legalization. I think also that the ones that are coming through the door have a lot, there's a more mixed bag of what they're using. We used to get kids that were smoking weed, and the parents were, very abstinent-based parents. So, a young person could come through, be smoking a few times a week or something, and a parent would be, no, this is so harmful. Basically, you're going to be doing heroin next week. And we don't get that anymore. So with the ones that we do see, are pretty serious. I'm losing the word, but it's polysubstance.
Complex? Oh, polysubstance,
Yeah, or multiple substances. Yeah. I think, do you want me to talk a little bit about how the services changed, or save that till later?
We can do that in your question a little bit later on.
Sure.
But so thank you for that.
Okay.
Great insights. Thank you. Perfect. And now Kim Bailey is there. She has a master's in social work and has over 25 years experience in the area of community and sexual health, with a focus on program development, leadership, and management. She's developed innovative programs in partnership with newcomers, Indigenous peoples, LGBTQ2S communities, women, and youth. Kim is passionate about issues related to health equity, social justice, and harm reduction. Kim, tell us a little bit more about your experience in the substance use field and in harm reduction, and about your passion.
There we go. Hi, can you hear me now?
Mm-hmm.
Good. Okay, just getting the Zoom thing down. So over 25 years, yes, it's been a very long time that I've been working in the field. It is a deep passion of mine. I most recently just moved back from Toronto, actually, but before that I was working at Healthy Sexuality and Harm Reduction, which is the Population and Public Health unit in the WRHA. I used to be Michelle's boss, so just so you know. So and that involved overseeing the Street Connections program and the harm reduction programming for Winnipeg. In Toronto, I was also involved in the establishment of a supervised consumption site at Casey House. They were in the development of that. So I've overseen an exemption application. And now I'm working at Nine Circles Community Health Center here in Winnipeg, overseeing the allied health program there. So I continue to follow in that line of work. I'll talk a little bit later, but like harm reduction is something that for me is it is about providing supplies to folks so that they are able to use in a way that is safer for them. But it's also part of a bigger picture around looking at the societal harms of how substance use is understood and treated. So a lot of the work that's being done at that level now is, in addition to providing service, is also to have a very critical look at the impacts of the criminalization of substances and the harms that criminalizing has for people who are using substances, and understanding that some of those harms are actually more harmful than the substances themselves. We do see higher rates of incarceration for Indigenous and people of color, mostly connected to drug-related crime. They tend to be criminalized more for that than white people. And so a lot of the work that we're doing now in the harm reduction field is really challenging that and challenging our notions of prohibition and how harmful prohibition and criminalizing actually is. So I'll end there.
Thank you. Thanks a lot, Kim. Kim will also be the J in this discussion, not J Pasternak, the J in Jewish, in terms of highlighting some of the issues there. So let's move on to Michelle. Michelle Klimzak is a registered nurse working with Street Connections program, the outreach component of public health's harm reduction and healthy sexuality team. Currently, in a coordinator role, Michelle supports a staff complement of outreach workers and public health nurses to deliver health care to those who experience marginalization in Winnipeg. The Street Connections program includes a physical location at 496 Hargrave, as well as a mobile service, which is available Monday through Saturday evenings. Michelle is currently pursuing graduate studies through the University of Victoria's Public Health and Social Policy Master's Program. Although a number of adventures have taken her elsewhere, Michelle calls Winnipeg home and is proud to work hard making this city a more kind and compassionate place. Thanks for being here, Michelle. So would you like to share just a bit more about your scope of your work?
Sure. Thank you so much for the intro, and thank you profoundly for the invitation to be here. As it will likely not surprise a lot of the folks who are listening in, sometimes harm reduction work can feel a little bit lonely. So anytime I'm in the company of those who are great advocates, I really appreciate that chance. I would say the biggest question I get about my job is, oh, it must be so hard, or it must be scary. And I guess that is the narrative that I look most to change. I would say the biggest challenge in my role is, in fact, what comes about from disparities in the systems. Working with people directly is where I take inspiration and encouragement in my job, as the clients that I encounter are resilient, funny, lovable, all those kinds of things that inspire me to do my job more further. I would say the other thing that led me into nursing specifically, though, is I think it's important to say that although most of the harms around substance use are rooted in community type scenarios, it's the health system that is most resourced around addressing those needs. So I realized pretty quickly that maybe I needed to hitch my cart to the health system. And, you know, there's pros and cons to that. There are boundaries in every area that you encounter in terms of a workplace, but I think that I found a great framework around where I can carry out the pieces of my job that allow me to enable folks to have the most, to be empowered in their choices and to carry out their lives in a way that feels good for them.
Thank you so much. We're going to now start with some interview questions, but I think first Michelle is going to kind of give us an overview on the basics of overdose. There's a lot of information on overdose. We're not going to even begin to cover all of it, but at least she will give us the basics about what overdose is and you know, what is the most common cause of overdose. Anyway, a whole host of questions that she will be answering today. Just take it away, Michelle.
Thank you. Okay, bear with me as I work through all the logistics. Share screen, and then I'm going to pull up my presentation. So far, so good? Yeah? Okay, great. Thank you so much, Megan.
You can
Thank
make
you.
it bigger, correct?
I think that those who are joining in would have to adjust the settings to
Under
make the
view
screen
options
bigger.
at the top, I think, of your screen.
Thanks, Ivy. So the first thing that I wanted to talk about a little bit, first of all, I wanted to situate myself as someone who can share the information from those that I work with most directly. So because of the privileges that I bring to the job, in terms of lived experience, I don't have that to share specifically or directly. So I just wanted to make sure that what I'm sharing, that people know that this is expertise that's shared from the clients that I have the opportunity and privilege to serve. Now, what I wanted to start with, as I've indicated, there's a lot of material to cover here, but I have a couple slides just to show folks, to walk you through what overdose looks like. And the first thing that you may have heard a lot of reference to is that there is a big push to reframe overdose as a public health issue. So I wanted to start by talking a little bit about what that even means, to frame something as a public health issue. And the way that I thought to bring that about first is to use a couple images that come from the most recent Winnipeg Health, the Region Community Health Assessment, which is available online. And I found this graphic, although it may be small on your screen, I can walk you through what it tells us. And I think the thing to zero in on here is that typically when we ask folks, what do you think about when you're thinking about health or healthcare? And often people tend to think about healthcare services. So they might think about, especially things like access to a family doctor or a health practitioner or access to a hospital. Whereas when we dig into what health really means and what in fact are the drivers around what is making Canadians sick, you'll see that there's a number of impacts that actually have not much to do with your access to things like a family doctor or a hospital. And in fact, about only 25% of your outcomes are connected directly to healthcare. The thing that I would draw your attention to most specifically is that 50% box that talks about your life. And in some of the opening comments, we talked a little bit about social determinants of health. And it's important to list off some of those things as disparities in the social determinants of health are what have most impact overall. So things like income, early childhood development, disability, education, social exclusion, social safety net, gender, employment, race, Aboriginal status, safe and nutritious food, housing, homelessness, and community belonging are some of the biggest drivers to our health status overall. The next thing you'll see, as I said, access to healthcare services does have an impact on your outcomes for sure. That accounts for about 25%. Then you'll see a smaller box, 15%, that accounts for your biology, and about 10%, which is accounted for by your environment. And although the type might be small, I just wanted to bring your attention to the fact that what you don't see listed in this box is any indication about choice or bad choices. What we know is that our health takes place within the setting that we find ourselves, and that's what I wanted to draw your attention to most specifically around what we're talking about when we want to frame overdose as a public health issue. Bear with me now again as I try to change screen. We'll see if I can advance my slideshow or not. Okay, here we go. Now, can you give me a thumbs up? Did you see it? Okay, thanks. Thank you for your cooperation. Okay, so when we talk about what are we trying to accomplish with a public health lens on an issue, I find this image to be the best synopsis of it. A lot of folks would be familiar with ideas in public health messaging, things like participation, would be ideas around trying to instill with folks that we have a lot of individual choice and responsibility for our health behaviors. But what we came to realize is that, as I indicated in the previous slide, this simply isn't always the case, because the systems that we find ourselves mired in account for a lot of our outcomes. So previously, the approach that we generally took was this idea of equality, where we wanted to make sure that resources were distributed fairly to individuals. But as you can see in the first slide under equality, if we give everybody the same thing, that doesn't necessarily help folks accomplish their goals, which in this case is to see over the fence, depending on where you find yourself in life. So in kind of advancing the agenda, especially within a lot of healthcare systems, we zeroed in on the idea of equity. And the Winnipeg Regional Health Authority does have a position statement on equity that helps to guide a lot of our work. And what a focus on equity tells us is that we distribute resources in a way dependent on people's needs. So this certainly does help to overcome disparities that exist amongst how resources are distributed. But what we find in talking to our clientele is that because we in positions of healthcare or other positions of power tend to have control over those resources, sometimes that's not the best fit for folks. So although we've become really good at identifying populations that may best need resources, when we tell people to climb up maybe really high on a stack of boxes piled up, that might not feel very safe for folks, and that may not in fact be the way that they want to accomplish overcoming a health challenge that they may have, or addressing something that may be occurring for them that leads to disparity. So where we want to move forward with approaches in the future, and especially with an approach like harm reduction, is to take a justice-based perspective. And in this case, what you see is we've taken down the wooden fence altogether. People can stand on their own firm footing. They all have the opportunity of accomplishing the goal of seeing the soccer game without having to step up on a tall box. And essentially, this is what we're trying to do with harm reduction, is make sure that folks aren't having to jump through hoops or stand on boxes to accomplish what they're hoping to in terms of their health outcomes. Now, the next thing, just to inject this is one of my favorite memes that I use in so many of my presentations, because I think we have to go back to the question of, if we have these great approaches in mind, why do we still find ourselves in the situation we're in, especially in regards to the overdose crisis right now? And a lot of our attitudes around overdose and substance use right now are informed by the war on drugs. And I really like how this captured it. We would like to congratulate drugs for winning the war on drugs. And I think it's important to acknowledge that although substance use can entail a lot of harm, when people begin to use substances, people aren't setting out to cause themselves harm. Quite often they're setting out to find benefit from the substances that they use. And quite often this is what leads folks to continue their use, is because there's benefit that they're accomplishing in some way through their use, regardless of what may be going on outside of their own individual experience. So the other thing that I think it's important to draw attention to is that we know that substance use is something that occurs population-wide, and we know that only a small percentage of substance use goes on to create a lot of harm for individuals. Again, as Kim referenced in her introductory comments, of course, my former boss. It's important to note too that those harms aren't distributed in an equitable way across population groups. So there too, we know that folks who encounter marginalization are much more likely to encounter harms from their substance use. And this is what we're looking to overcome with an approach like harm reduction, is that we give folks the individual tools to approach challenges in a way that's most meaningful to them. That can be through specific tools like clean supplies, or it can be through more structural approaches. So now, how does this all connect back to overdose as the question that was initially asked? I'm getting back to it. I wanted to show you this picture of the Street Connections van. It's a beautiful evening, a beautiful summer evening out in the Street Connections van, and kind of touches back on what I was speaking to you before, that when people ask me, is it scary out there? It's not scary. The systems are scary. And I think that especially in light of COVID-19, it's important to talk a little bit about how structural issues and systems system issues have led us to the situation we're in right now in regards to the overdose crisis. So a few things to note about our Winnipeg context specifically. Starting in about 2015, crystal meth began to be the most commonly used street drug that folks were naming and referencing. And that had some specific impacts on how systems were structured. And we continued to try to do work to address what folks were encountering over the ensuing years. And really the only thing that changed things drastically was border closures related to COVID-19. So although opioids were readily available here in Winnipeg, it seemed to be that what was driving a lot of the harms we experienced in regards to substance use was crystal meth up until very recently. So with border closures, our ability to kind of, move all kinds of goods across the country was dramatically impacted, including what was available for supply of street drugs. So the thing to note too is crystal meth is a stimulant, which has very different impacts than opioids. So when we suddenly remove the supply, it's important to note too that for folks who are using substances, whether it's alcohol or something else, quite often people don't have the specific substance that they stick to. And this is true too when you think of the analogy of using alcohol. There wouldn't be many folks out there who say, oh, if you're offered maybe a glass of wine, you're probably pretty unlikely to say, oh, heavens no, like I drink scotch only. Like you're quite likely to use what's ever available to you, and this is true of street drugs as well. So opioids seemed to become the predominant drug of use over the summertime here because that's what was available. And that created a couple problems. First of all, opioids are what is highest risk for overdose. And the other piece about that is because a lot of folks didn't have much familiarity with using opioids, they didn't have much tolerance, and this led us to be in a situation of really high risk opioid use that led to increasing overdose rates. The interesting thing around this too is that some of the messaging around COVID-19 is in direct contradiction with what we tell folks around substance use from a harm reduction perspective. So the COVID messaging of, stay alone, don't leave your house is in direct contradiction of the harm reduction messaging, which would encourage people to use within a peer group where folks can take care of each other and be there in the potential possibility of responding to overdose. So a lot of the messaging that came about put us in a situation where the resources simply weren't in place to be able to respond adequately to what folks were experiencing on the street. So we really ramped up supply distribution and naloxone distribution as much as we could in Winnipeg, but we are faced with a couple barriers. Number one is that although naloxone is not a prescription medication, you do require a healthcare provider to provide some training around its use, and not everyone has access to a healthcare provider. So we've worked a lot on some systems and structural barriers there, but one thing that we would advocate for from an ongoing advocacy kind of piece is to unschedule naloxone, meaning that it wouldn't require that connection with a healthcare provider specifically. So that's an advocacy piece that we are working on currently. That kind of gives you a little bit of context in regards to where we're at with the opioid situation here in Winnipeg specifically. And I wanted to zero in a little bit more on what that means in terms of naloxone distribution. So just to take one step back, I would say resoundingly that when I ask clients, if there was anything you wanted me to share with people, what would it be most specifically? And as Kim referenced and as Megan referenced too, quite often it may be the substance itself that's causing harm, but oftentimes it's the structural issues that people are encountering or the stigma around their substance use that causes harm. So there is a piece to play in terms of specific tools that is at our availability, and naloxone is a great tool, but taking a moment to reflect on your own ideas about substance use is something to think about specifically. The other thing to think about is the context in which naloxone use, in which substance use occurs. And the thing to note there is that you'll see this is what a naloxone kit looks like. It's administered by injection, and if someone is already unconscious from overdose, it's very unlikely that they'll be able to administer it themselves. And I point this out specifically because what we know from the stats in Winnipeg is that if you're using alone, that's what puts you at most risk for a fatal overdose. So I can't say enough about encouraging open conversations about overdose, which is what makes me so encouraged about being invited to participate in a panel like this, is because it gives me the chance to talk about how to keep yourself most safe. So around access to naloxone, just a few points to draw your attention to. Number one is that anyone in Manitoba can access a naloxone kit. Ivy was going to share a resource around the number of points that you can figure out where to get a naloxone kit. Through the College of Pharmacists of Manitoba, they have listings of every place where you can get a naloxone kit. It's important to note too that naloxone kits are available free of charge through a provincially run program called the Take Home Naloxone Program. Street Connections is one of the busiest distribution sites for naloxone. And I point this out specifically because in Manitoba, you're eligible for a naloxone kit free of charge, either if you're at risk of overdose or if you are the friend, family member, or loved one of someone who's at risk of overdose. To access a kit, it involves a training session that takes about 20 minutes, and then you're provided with 1 or 2 kits depending on your needs from there. On the Street Connections website, we have a listing of all the take-home naloxone distribution points, so those would be the points where you could access a naloxone kit for free. Now, the kits that we provide here in Manitoba are by injection, and I did want to draw your attention to the fact that you can administer naloxone through a nasal route as well. And the thing to point out there is that for folks who have treaty status, those kits are available free of charge through Brothers Pharmacy, so I would point you in that direction if that's applicable to you at all. If you're buying one out of pocket for a nasal naloxone kit, it costs in the range of about $150, but for an injectable kit, if you are paying out of pocket, you'd be looking at a cost somewhere between about $10 and potentially $40 if you're paying out of pocket. But I really want to reinforce the information that take-home naloxone is available free of charge for anyone who may be at risk of overdose themselves, or maybe the friend or family member of someone who is. Now, in terms of addressing open dialogue around risk of overdose, it's important to note too, you can overdose from all kinds of substances, but what puts at a specific risk around opioid overdose is because it causes loss of consciousness and interferes with our breathing processes. So sometimes we think about overdose specifically attributed to street drugs, but I wanted to make sure that you know that it's prescription medications in large part that are driving the opioid crisis. And just to name off a few, these may be relevant to medications that you know friends or family members are using. So I wanted to make sure folks know that opioid overdose is caused by the category of substances that are called depressants. And under that category, we find opioids specifically. And just to list off a number of them: codeine, fentanyl, hydrocodone, hydromorphone, oxycodone, heroin, methadone, and Demerol are all medications that you should be aware of. If anyone within your peer group might be using, then you are well positioned to make sure that you have a naloxone kit. Now that kind of covers, I know that's a that's a quick blast through all the information around opioid overdose. So I wonder, Ivy, if there's anything you wanted me to touch on in a little bit more detail, please let me know. But otherwise, I will turn it over to the discussion portion of the panel.
Thank you. Thank you. I think you've covered it all, Michelle. I was looking over my questions, and as we were getting towards the end of your talk, I was realizing you had covered everything. I don't need to ask you anything more, but there may be questions at the end of our discussion that may come up. And I just wanted to, Megan, I think you did mention the benefits of Suboxone and methadone. I'm not sure if you had anything to add to that, or whether we should just move on.
I mean, I feel like I probably covered it. I feel strongly that the reason I'm here to tell you my story is because I have had access to these drug replacement therapies since I was about 20 years old. The only thing to stress is like a well-supervised regimen is invaluable. When I took my medication into my own hands is when I ran into a lot of trouble. That's like the only thing to really drive home about it. I can't say enough good about it. I feel very strongly for it. Other people may feel other ways, but that's my opinion and it's my experience.
Thank you. Thank you. Thank you for that. So let's move on then to Jay. In terms of your experience at JAX, you did indicate that your agency has adapted to the new normal. It sort of has changed its way of working with people. Can you give us an idea of how your agency has changed over time? Also, what your clients have experienced in terms of COVID-19, and how your agency has adapted.
Great questions. So, well, JAX, originally JAX stood for Jewish Alcohol, Chemically Dependent, and Significant Others. I had to look that up. and it was based out of New York. Some of the first groups that started were based in New York, and it was started for Jews who didn't want to go to churches for AA meetings. So a group of like-minded individuals in New York came up with Jax and said, there's no reason why everybody should be going to churches. We'll hold our meetings in a community center. And that's where it first started out. When we brought it up to Toronto, it's similar to Winnipeg, Montreal, Vancouver, we started to look at what the needs of the community were. And because Jax had started as a 12-step grassroots program, we started looking at the groups that we were getting, the clients that were coming through the door, and not everybody was walking in with love, hope, and honesty. Most people were crawling through the door, and Jax was like the last house on the block. They've been kicked out of most other places, including family homes, and we decided to change the philosophy to make it more of a, I like to call it your booby's living room. So we brought in a bunch of couches. We had a very non-judgmental attitude with all the employees. And our philosophy changed from a 12-step approach to meeting the client where they're at. And originally the groups were run and they were all 12-step based, the first few that we ran for the first few years. And that morphed into more of a, like I said, a meeting the client where they're at approach. I don't know a lot of people that walk into a counselor's office with a drug or alcohol problem or other addiction problems saying, geez, I can't wait to give up all my friends and everything that I do in life and change every aspect of my life, because that's basically what they're saying when you're saying give up drugs and move to a zero tolerance policy. I could see in my private practice as well that having that approach was very narrow and we weren't serving the greater community. And much like Megan, people have to they have to kind of crawl before they can walk and run. And some people in our agency will seek abstinence, eventually. But while they're doing that, we want to support them in the safest way possible. And that's if giving out needles. We don't have needles on our site, but we have sites, various shelters around us that have needle exchange programs. The one thing that I always encourage people, I was going to put it up in the notes, was if you have naloxone kits, don't keep them in the bathroom. Chances are somebody's IV opiate use, they're going to be shooting up in the bathroom. And if the door is locked and that's where the naloxone kit is, you're going to have some problems. So what I tell people is keep it in a very general space, keep it in a kitchen, something that's accessible to everybody. And, God forbid if somebody happens to pass out in the bathroom or overdoses in the bathroom, you've got the kit and you can get the door open. Hopefully you'll get the door open. But at least you've got the kit too. And, I don't see the harm in kicking down a door to save a life. Having said that, I think, just as Kimberly has said and Megan has said, opening up methadone clinics. I know when I was looking myself years and years ago for opiates, they used to say to methadone addiction rehab center would say, come back with 3 days clean. And I used to say, if I could get 3 days clean, I wouldn't come. That was for methadone. You had to be 3 days off of opiates. If I could get 3 days off opiates, what would I do with your clinic? That'd be like a lifetime. So now it's much more readily available. There's doctors everywhere that have licenses for it. Naloxone's available in pretty much every pharmacy. You just walk in and say, I'm involved with addicts. You give them your health card and you get a naloxone kit. I think they always say, have you been trained in it? And they might say, go through the step-by-step instructions. Most of it here is nasal as well. so it's pretty easy to administer. And I don't think that you can you cannot give too much of it. I think that was it for, how we changed because of COVID. Just very quickly, our numbers have gone up straight across the board, 30% for sure. In some areas more. We're seeing a lot more mental health issues. We had started, we had one group that was running a men's group in the mornings. One morning a week, we changed that. Now it's running, actually it's 7 mornings a week. They're running it on Shabbat as well. One fellow's taken that over. I don't think it's the people from our direct agency, but one of the fellows in the group is taken over the Saturday group. And, we just found the need that people were waking up with so much anxiety. We started a meditation group at 10 in the morning as well, because people, with the first pandemic that closed up everything in Toronto and surrounding, we were saying people that were just afraid. They were waking up filled with fear. I'd mentioned to Ivy and some of you earlier, the thoughts of, do I go to the store today? Who can go to the store for me? When I get my groceries, should I be spraying it down with alcohol, the bags? If I get a parcel in the mail, do I leave it sitting in the garage for 2 weeks? So all those kinds of fears were what people were going through. So we've expanded we've put together a 6-day-a-week meditation group at 10 a.m. And that's kind of morphed into, it went from 10 to 10:20, and now that's morphed into a group that runs until about 10:45, because what we found was after the meditation, people wanted to speak to each other, they wanted some fellowship, they wanted to connect with other people, and we've done that. As well, the men's group, there were a lot of men that were unemployed. We didn't see as much, the women, it seemed like, I don't know, maybe it's my nature, but just didn't seem like we were getting the same numbers of women. Maybe that, people were looking after their kids, or they had other at-home jobs, or they weren't connecting. We put it out for a women's group to run every day, and we just weren't getting any numbers coming out from our women's group in the evening. Not like the men's group. I think men's group can be up to 30 people at a time. We're going to keep doing it and keep putting on a women's group in the morning, and we'll run it for probably another, from time to time, run it for a week or so and see if we get numbers coming out to it. It could be also the word of mouth and the way we advertise. So we're going to be looking at that as well. So I think that's it for me.
Thank you. Thanks for all that. That's great. Good information. And interesting insights about who's coming out to your programs, and the issue with women coming out. I did want to say, just let people know that this is not an anti-12-step program, but we just wanted people to be open-minded about a harm reduction approach. We believe in a comprehensive approach, and people having all kinds of options, basically, to recovery in their own way. So I just wanted to make that point. Now we're going to
Can I just jump in quickly?
Sure.
Just to say that is part of a continuum of care, from using and not from using to abstinence. That there's all levels of healthcare along that continuum, and abstinent 12-based program, we need them, they're a necessity. Methadone, opiate replacement therapy, street outreach, it's all needed to save lives.
Exactly. Thank you. Right, so let's now move to the Jewish piece of this program. I'd like to ask Kim how harm reduction is a Jewish concept, and why is it a good fit with Judaism and Jewish approaches?
Yeah, so thank you. And I also just, before I start, I'm not going, I'd like to just thank Megan for her really open and honest and insightful sharing of your experience. It takes a certain amount of bravery, and I have deep respect for that. So thank you. And also what an incredible example you are of kind of how come harm reduction is so important and how it actually works. A lot of times we think that harm reduction is enabling drug use, or, you know, like, why would we give people stuff so that it would, you know, further their, you know, their use or things like that. But ultimately it's there because we do it because we want to keep people alive, so that in the event that they do get to a point where they are somewhere else on that continuum of recovery, they are alive and able to do that. And you illustrated that really beautifully, so thank you. From a Jewish perspective, the concept of preserving or saving a life, which is in Hebrew pikuach nefesh, is a really fundamental Jewish principle that I think is one that very much aligns with a harm reduction approach, which is ultimately to save lives. And in some ways it takes, in Judaism, takes precedence over everything else. And so that's why I think like harm reduction is definitely in line with a Jewish philosophy. I'm sure, like, Judaism is a big ocean, and there's many different perspectives and different ways of practicing and understanding the Torah. And so I'm just going to talk about it from a harm reduction perspective. And the reason why I'm doing that is because for me, what I do in my professional life and who I am as a Jew, it's really important that those things mesh. And so as a result of sort of, you know, spending a lot of my professional life in the harm reduction world, was curious to see how Judaism grapples with some of the same issues that we are talking about in the field of harm reduction. So that's what kind of led me to think about it a little bit. And a few years ago, in fact, I did a talk at the local Limud. I don't know if people have heard of that, but on does Judaism take a harm reduction approach? And so from my perspective, it can. I don't know that it always does. So one of the things that I'm just going to do what's called like kind of a small Dvar Torah, like a little conversation and learning from a particular section of the Torah that was we read probably just a few weeks ago, and that is in the book called Noah. And so probably most people are familiar with the story of Noah and the ark and the flood, and sort of what happened. Like, he was sort of instructed by God to build an ark because the world was going to be destroyed. And of course the world was, but then eventually they found land and they reestablished themselves with the animals that they had saved and the family that he had saved. And in that same parsha, or that portion of the Torah, there's a little story about how Noah, after the flood, creates a vineyard and uses the vineyard to create wine. And there's a story about him passing out from being so inebriated from the wine. And then one of his sons discovers him, and when he discovers him passed out, he notices that he isn't wearing any clothes; he's naked, and then runs to his two other brothers to tell them about that. And the two other brothers come in, and with great care and discretion, so they don't even look at his nakedness, cover his body in respect, for their father. So what I find significant about this little story is, first of all, that the Torah bothers to mention that what Noah decides to do with his time after the flood is to actually create a vineyard. We don't hear about, he could have made many, many things, or we could have been learning about how he, I don't know, did a field of wheat, or, whatever, grew all kinds of things. And so the fact that it pays attention to the creation of this vineyard to me is a really powerful, it can teach us a couple of things. One is that substance use has been with us from the very beginning, and it is something that humans do in order to enjoy life and also to help manage trauma, which you can imagine that he had just lost practically everything in his world, and that he might not be in the greatest space. And so therefore is, like a substance use as a form of managing trauma, it was right there with us at the beginning as well. It also has some other interesting teachings with regards to how his family responded. So he had three sons. And the one thing that happened was after Noah woke up from his stupor, he curses his son who told his brothers and blessed the sons that covered him. And so there's a lot of commentary on that. But what I would like to sort of point out, one of the commentaries says that the reason why the son that told on Noah was cursed was because of the shame that he was demonstrating when he spoke to his brothers. There's kind of this sense that he was going out and speaking badly about his father, as opposed to his two other brothers who supported and showed love and respect to his father, to their father, even in his moment of weakness, I suppose, and they were blessed for that. So I think that's a very powerful message in terms of what does one do in the face of folks who are using substances, and shaming and stigmatizing them is actually a curse, and supporting and loving and connecting to people who are using substances is actually a blessing. So that's one one little insight in terms of a Jewish interpretation of harm reduction or substance use.
Thank you.
The other is in terms of keeping kosher. So I know a lot of people may or may not practice kosher, but just to say that the ideal in Judaism is that people, like from a Jewish perspective, is that the people are vegetarians, that we don't actually eat meat at all. Like the sort of spiritual ideal is to not eat meat at all. But the Torah recognizes that that's probably very, very difficult for most people. And not to say that meat is like a substance, but just in terms of the approach is to kind of recognize that yes, people are going to do it. So how do we do this? How do we support people in their natural inclinations to eat meat? And how do we reduce the harms of that to the animals and to the people themselves in terms of what eating meat might be? And so what we do is we don't eat any meat, like we only eat, we don't eat, like there's sort of limits on the kind of meats that are allowed in a kosher framework. And also when the animal is slaughtered, we do it in a way that is a religious blessing, and also done in a way that reduces the harm to the animal. So for me, it very much resonates with a harm reduction approach, with sort of a recognition that people are going to use substances. So how do we do this? How do we support this in such a way that kind of reduces the harms of that? And so that, I think, is another piece of Judaism that kind of resonates from a harm reduction approach. And also to understand that alcohol itself is not prohibited in Judaism. There are no, like you see right away, like with Noah in his vineyard. And also in terms of many of our religious practices are very, every Friday night, there's a blessing made on the wine. During the Seders, we have, 4 cups of wine. There are actual, the holiday of Simchat Torah, where there's a lot of substance use and partying that goes on. And during Purim, we're supposed to drink so much alcohol that we can't tell up from down, or like good from bad. Like things have, like So there's definitely allowance. There is for alcohol use within the Jewish religious or Jewish cultural context. So from a prohibition perspective, which is to say, no, we should never do it, or it's all bad, you know, and to shame people for doing that, that is definitely not part of the Jewish perspective on substance use or alcohol use. So that's my little, the 3 examples that I just want to share tonight with regards to a Jewish understanding of substance use.
Thank you. That was really, really interesting. Thank you for that. Dorit, do you have anything else to add in terms of why someone would want a Jewish approach to a Jewish informed approach?
Yes, Ivy.
Okay,
I do. So, yeah, so right now in the North American community, I think there's a groundswell happening of Jewish programming that's looking at addiction and recovery and treatment. We have Elon Glazer as part of our audience tonight. He's leading Our Jewish Recovery, which is a Facebook group that has Torah study. They have 12-step Jewish focused conversations, and they have special events, and there are hundreds of members. So people, Jews, are obviously looking to make that connection. They're seeking it out. We also have Beit Teshuvah in Los Angeles that has started 5, 6, 10, many years ago, started doing trainings for Jewish organizations and individuals who work in addictions. So this is becoming more of a thing, right? And it's important because understanding the nuances of culture and identity can really be key for helping people and helping them to connect to their core truths. So when I came to Winnipeg a couple of years ago, what I noticed front and center getting to the city was the amazing work that has been done in the Indigenous community and outside of the Indigenous community in terms of reconciliation. And what that sort of looks like is really having a good understanding of historical traumas, what that looks like in each generation down the road, and using ceremony and rituals and how those can be very healing. And while the Jewish experience may be very different down the road, it still has followed a pattern. We come from a specific traumatic history sometimes. We come from an immigration, at least an immigration history. We all have cultural nuances that relate to who we are as Jews, whether cultural, religious. And so finding those unique Jewish spiritual things that can appeal to people are important. I met an Indigenous woman who was addicted to crack for 30 years, and she now makes bannock for her entire community. And I recently had a client send me a picture of herself making challah with her daughter. And she's in recovery, and it occurred to me that how similar those two things are. There's something very deep about our connections to challah in the same way as there is to bannock. And that's what we're trying to do at JCFS and through all of the other Jewish programming that's happening around North America that we're supporting each other with. So.
Thank you so much, Dorit. That was really excellent. Thank you. Does anyone want to comment on if there are any, it's difficult to generalize, but some of the issues that might specifically relate to Jews. You covered some of it, Dorit, specifically related to Jewish, being part of the Jewish community, that might be a risk for addiction or protective factors for addiction. Does anybody want to comment on that quickly, because we're running out of time, but I just wanted to ask that quick question before we move on.
Sure, I'll throw in just for a quick minute. I think, being raised in a Jewish household, I think quite a few of the Orthodox people that come through JACS as well, not that I was raised as Orthodox, but it was kind of a, if you had a strong Jewish faith, you couldn't possibly become addicted. And there must be something missing in your Jewish, upbringing or your observance of Judaism that's causing this problem. And for some in the community, I think that as Kim saying it, kind of stigmatizes and shames people, and they stay away from recovery. I know quite a few Jews that we had quite a few synagogues when I first came around that were having 12-step meetings in them. And a lot of people had said to me, you know what, I can't go to a synagogue. I don't want anyone to see me, And I think, hats off to Megan, who, her family was very accepting of the problem and encouraging and supporting her positive steps forward. I think that's changing somewhat, but it's still a very big hurdle for us to climb. And hopefully with awareness like these workshops, we're doing that. And the Facebook recovery,
Our Jewish recovery.
Our Jewish recovery sounds great. Yes, that's my take.
Thank you. Anyone else?
Can I just jump in here for 1 second with something,
Sure.
just something that Jay said? I've always found it interesting that recovery should somehow be shameful or hush-hush. Like when we are in, or certainly when I was in active addiction, even if I thought it was a secret or I was keeping it quiet, it's never really a secret. People know when you're out and in the throes of addiction and the insanity of the disease. So it's always seemed a funny comparison to me that why, when we get well, when we're doing our best, should that be the time that it's like, shh, it's a secret. I don't want anyone to see me. It's just, it's a strange frame of mind and something that should change. That's all I wanted to say.
I think one of the things that I run across often with people is that addiction is a choice. People have a choice to drink, people have a choice to use drugs, people have a choice to smoke a joint. And that's probably true in early social use. But once it crosses a threshold, people don't have a choice anymore. They have to use. And so I think there's always been a stigma that mental health, you don't have a choice if you have depression. But walk into an emergency room with a doctor, and oftentimes the doctor will say, listen, if he wants to drink like that, that's his choice. And they really, it's still out there that, we lose that freedom of choice. And I think that's what a lot of the 12-step programs will say, that we've lost freedom of choice. And for some people, they lose it right away. They put a chemical in their system and for whatever reason, genetic factors, environmental factors, that just their mental health makeup, that they seem to, become far more susceptible to substance abuse than others. I think it's kind of this moderation piece. Some people have it, some people don't, right? Mm-hmm. Some people can moderate, some people can't.
Mm-hmm. Yeah, I think you're right. Thank you. So final question for everybody. I do want to leave, it's almost, it's 8:26. I do want to allow for some questions after this final, questions from the audience from this final question. So could people comment on what we as a community can help reduce the harms? Again, getting back to the Change Begins With Me theme of this year's substance use and awareness theme. Who would like to go first?
There's a really a good book. I'm just blanking on the name of it now because it's late for me and it's been a long day managing COVID in a health clinic. But the author is Johan Hari. He's a journalist from the UK who has written very powerful books on the topic of addictions. And his saying is, or one of his taglines or things that stands out for me is that the opposite of addiction is connection. And so, and I think that speaks to the Noah story as well. And so and I know connecting with people who are actively using can be very challenging, and same back. But I think that that is just something to sort of keep central in our minds as individuals as well as a community, to stay connected. And I know it's hard now with COVID. I get that.
Right, I was going to say, but even in other ways, virtually, I agree. Anybody else? Okay. Okay, well, I think, oh, it's called Lost Connections, Al says, in terms of the book by Johan Hari. So, okay, so I think that's a good way to kind of end our conversation. And I would like to now, I guess, open it up to any questions from the audience, if we have any. Al or Dorit or Shanna. I'm going to look.